Ready?
All right.
Okay. Hi, Rose.
Hi.
Nice to see you again.
You too, Stuart.
And thanks for doing this interview with us.
Absolutely. Thanks for having me.
So for our audience, Rose is the Executive Director of the Minnesota Nurses Association since 2014.
Yes.
And she's also on Attorney General Keith Ellison's task force on lowering pharmaceutical prices.
Right.
So, yeah, thanks.
Yeah, thank
you. So we'll get started. So
Okay.
the first question is, what does single-payer healthcare mean to you?
Very simply, what it means is freedom. Because right now, this idea that we have freedom within our healthcare system is a misnomer. We are constantly dictated to in regards to whether it is cost, whether it's the network, who we can go and see when we are sick and when we need help. And so single payer removes the barriers. So we can't have life, liberty, or the pursuit of happiness if in fact we don't have our health. And in order to have our health, we need to have freedom to be able to actually go to the doctor when we're sick and not have to worry about going bankrupt in the process.
Yeah, that totally makes sense. So how would a single-payer system, how would it positively affect our nurses in the state? And what are some of the issues that nurses are facing in our current broken system?
Well, nurses will tell you that, first of all, the patients that they are seeing these days are much sicker than they have ever seen patients before. And that is attributed to the fact that people are not accessing care at the lowest level because of the cost, again, the cost barrier, whether it's a copay, whether it's a deductible, a co-insurance. They're not going in with the first symptoms, and therefore they're ending up in a situation where they are much sicker than they would have been if they could have gone and accessed care sooner. The president of MNA tells a story about, she's an ICU nurse, and she's in an ICU one weekend, and she's got a couple of patients there. Both of them, they're intubated, so they're in a coma, and it's a diabetic coma. And when they come out of it, and she asks, why didn't you take your insulin? One said couldn't afford it. The other one said his son was also a diabetic and his son couldn't afford his insulin, so he was sharing his insulin with his son. So talk about being penny wise and pound foolish in this system that we have. A day in the ICU is about $15,000. If we had reasonable costs around insulin, which we absolutely should have because we know it doesn't cost what they are charging for it, we could actually save a whole ton of money. I mean, you pay a few $100s to get the insulin up front, or you pay $15,000 a day for 3-4 days in the ICU. That doesn't even make sense. And the other thing that I would say is that nurses want to spend more time with patients at the bedside, as opposed to being at a computer. They are at these computers. They talk all the time about chart is what they say, because all they're doing is inputting this data, not necessarily related to patient health outcomes. It's all about how to get the hospital paid and the coding. So those kinds of things being removed would immediately mean that nurses get to practice their craft.
Okay, and I think we can move on. We can move from this question into I've heard in the news about some issues with staff ratios at hospitals, and my understanding is a lot of nurses are being overworked, or they have to see too many patients. Is this accurate? And does Medicare for All or the Minnesota Health Plan would it do anything to address staffing ratios?
Yeah, I think it would indirectly. I mean, the Minnesota Nurses Association, along with our national affiliate, National Nurses United, are working both nationally and in various states on legislation that would implement staffing ratios in our hospitals. When you think about doing child care, and you think about that it is like one adult to, I think it's no more than 2 infants, right? There's a reason for that, obviously, because you can only take care of so many infants at one time and do it and make sure that they have the safe care that they need. Why would we not establish some sort of a standard around the care we get in a hospital when we're at our most vulnerable, to make sure that the nurses are not overtaxed based on the acuity needs of the patients that they're taking care of. So we do have staffing crisis going on in this country, in our state. It's particularly difficult in rural Minnesota, of course, and in the rural areas. So the way that indirectly Medicare for All or the Minnesota Health Plan would begin to help with that is that we would have global budgeting. And so hospitals would be provided budgets based on regional health planning, so they would be able to staff according to the needs of the community and the needs of the patients, not just the bottom line of the hospital.
Okay, thanks. Okay, and we're at a nurses union right now.
Yes.
So what role does labor have to play in healthcare reform?
Well, it has a huge role to play.
Okay.
If the nurses have anything to say about it, I'll tell you that. Think about it. In the last couple of decades, the number one issue that has been involved in labor strife, strikes, whatever it is, has revolved around this issue of health insurance. Because we actually have a common enemy with our employer. This industry that continues to drive prices up, and we never know exactly why are they driving the prices up. Where are those prices coming from? We are realizing wage stagnation in this country, certainly labor unions, as they sit at the bargaining table, because if we get some money on the table, 9 times out of 10, folks want to put the bulk of it into the increased cost of that insurance premium. And when we do that, then the whole economy suffers under wage stagnation. So my feeling is that if all workers outside of those that are in organized labor are beginning to suffer and lose more and more access to this benefit, it's only a matter of time before we will start to suffer that in the labor movement as well. This is about solidarity.
Yeah, and I'm in a union myself, and I was just told that our contract proposal is our healthcare costs are going to go up 7% next year, and people are happy about it.
Right?
You know?
Yeah, because it's not a double digit. Woo!
Yeah, because it's not double digits. So it just seems like it's either wages or healthcare.
Right.
You know.
And one of the things that they will many times, I've sat at many tables where they send in somebody from the insurance industry to basically tell us that it's going up because it's all our fault. Because we used the product. Well, I thought that's what it's there for. What is that about? You're supposed to be able to use it if you're sick. And it's because, somebody had cancer, somebody had a premature baby, and all of those things supposedly drive up the cost. Well, that's the whole idea of a healthcare system, is to take care of those kinds of needs. And it's just ridiculous the way that they pump those prices up based on the fact that we simply use the product.
Yeah, and it just keeps going up and up and up. And
yes,
it's not, unless something changes.
Right. I was recently at a bargaining table where we were discussing this, and the employer said, well, we don't know what's going to happen, in 3 years with healthcare costs. I said, I know, it's going to go like this. Why would it abate? There's nothing put, for all the good things that were in the Affordable Care Act, such as dealing with industry abuses around things like pre-existing conditions and, lifetime maximums, and the expansion of Medicaid, which was really an important and good thing that happened because many people got access to care for the first time, in some cases literally in their life. The reality is the bill had no proven cost containment. And we didn't change how we pay for health care. So that's why this continues to happen.
Sure. Now, in some of the maybe more conservative or moderate unions out there, they have this criticism that if they've fought so hard for their good health care plans, and if we just pass a single-payer health care reform bill, it's just going to throw all that away. It's going to get rid of their good plan that they fought for. So how would you respond to that criticism?
Well, I would say that I continue to maintain that it's a failed strategy to think that we can bargain health care. I don't know why we want our employers controlling our health care. Because think about it. That's what's happening. Because if every year that employer, who's also sick of this, by the way, has to go out to bid, has to figure out, well, can we afford to stay with, Blue Cross Blue Shield, or do we need to switch over to Medica, or do we need to go here or go there and back and forth? When you're doing all of that, that's a ton of administrative waste, a ton of resources that the employer is putting into it, and now they settle in on something, and guess what? Now that new plan doesn't have your doctor that you're in the middle of treatment with. And now you have to switch over. So your employer, not because because they want to, but just because it's the nature of the beast of the way this system is structured with employer-provided health insurance, they've actually made a decision that's incredibly impactful on your life.
Sure.
Why would we want to do our healthcare that way? Our healthcare should be between us and our doctor, our nurse practitioner, right, our provider. And I would also, I guess, add that I don't know how many, there might be a few unions still, God bless them, that are able to hang on to like the really gold, platinum, diamond, whatever we want to call it, great plans
Sure.
that have almost nothing out of pocket, and they're not hard, and their employer is picking up the bulk of the premium, if not all of it. That is few and far between. Look, even nurses are paying significant amounts of money for their health insurance premium in addition to all of their out-of-pocket costs. It is not something that makes sense for us to continue to try to bargain. We should move to a place where it's off the bargaining table. Let's start shoring up things like, defined benefit pensions. Wouldn't it be wonderful in this country if we could have people retiring with dignity and economic security again? We've lost that in this country. Let's provide other types of benefits that make the union an even better, place for people to work under a union contract, like elder care and child care, and increase the types of apprentice programs to help folks that aren't maybe college bound, but could still make a wonderful living and have a great life and enjoy life by having good, solid union jobs that pay good wages and have those other type of benefits.
Yeah, and in my union, there's so many people with great ideas and great ambitions for what the union can be doing, what they can be fighting for, like dealing with the student loans that a lot of our members have.
Yes, exactly.
And things like paid family leave.
Right.
That's not something that we get currently. So, and it just seems like if we're always fighting for healthcare,
right,
there's all these other things that aren't getting the effort that they deserve.
Exactly, and I say this often, but I absolutely believe that we have to have a conversation in the House of Labor about the fact that this particular benefit has become a tool in the class warfare that we are engaged in, because we are literally shifting our wealth as workers to the insurance companies, the PBMs, and big pharma. Why are we doing that? Makes no sense.
No sense.
And it's not a value added on the bottom line of the balance sheet or the profit and loss statement for the employer either anymore.
Yes. So now if we could switch to your work on the
Sure.
pharmaceutical drug task force. I know you've been doing some great work with it, with Keith Ellison's task force. So can you tell us a bit about what you've done so far and what's yet to be done?
Yeah, I'm so honored to be on this task force. I so appreciate the Attorney General, including the nurses in this discussion, right? And I'm chairing actually one of the work groups. It's called Causes and Contributors, and I got to be honest with you, I am learning a ton in participating with this particular task force. So accomplishments are still in the works. So there's nothing yet, written in stone. We're working on beginning to sort of think through drafting what kinds of recommendations we want to make, particularly as they impact both state and federal legislation, or could impact. Is there possible litigation areas that the Attorney General's office could be looking at? And we even want to include a bucket that is about patient education. What are things we want people to know about purchasing, pharmaceuticals? I will tell you that it is a couple of things that have just really stuck out to me. It is clear that the monopoly that pharma has is not a natural market monopoly. It's a granted monopoly. The government has given them this monopoly. And that goes along with patent abuses that go on, and even this direct-to-consumer marketing that happens, which is 3 times more in their budgets than research and development is. Most research and development, as we know, is done by the public already, either through the National Institute of Health or at our universities. And so this little red herring they like to throw up, oh, if you take away any of our money, we won't be able to do the fabulous research we're doing. They will go ahead and change a single molecule, or they'll take a pill that's in a tablet form and change it to a capsule, and they'll get a new patent on it. It's absurd what is going on with this. So we need to instead take that money and lower the drug prices.
Yeah. So, the government's paying for it, and the pharmaceutical companies are gaming the system to
exactly.
patents and
Right, because they buy them off of, and then they take and they get them patented, and then they go and they just put layer upon layer upon layer of profit margin on top of it, simply because they now are trading on Wall Street, so they legally have to make a profit. That's why you can't have healthcare systems be profit driven, because the only way you can make a profit off of something like that is denying care somewhere along the path.
So you talked about pharmaceutical benefit managers. I know you mentioned them.
Yes.
Because I think a lot of people like myself had never heard of them before a few months ago, because I know there was a bill passed that was a little more regulation.
Yes, licensing them. Yes.
On these benefit managers. Can you talk a little bit about what they do, and like what would, if we passed a single payer healthcare system like Medicare for All or the Minnesota Health Plan, what would happen to them? Would they still exist?
Well, so I'll start with question number one. I'm a little bit tainted when it comes to PBMs. They're really nothing more than another unnecessary layer, within the system. They really are superfluous, because under the current system, if we're going to keep this current system around for any length of time, we have to do much heavier regulation of them. For instance, this idea that, they're going to negotiate between, the health plan and or the provider or whatever it is and the manufacturer. They're going to be the middleman in that. Well, here's the problem is that then they say, well, we'll get rebates, right? And then those rebates will help bring prices down. What we're finding out through the work we're doing at the Attorney General's task force is that many times they keep the rebate. They don't give the rebate to the actual payer. They're able to figure out how to keep that and put it into their bank account. So one thing we have to do is we really do have to get serious about much more heavier regulation around these PBMs. Under single payer, I'm sorry, but there's really not a whole lot of need for a PBM, simply because we will be able to do bulk purchasing of pharmaceuticals and negotiate directly with the manufacturers, like every other industrialized nation in the world does with our pharmaceutical companies, except we don't, because it's against the law for us to do it, at least in the big program that we have, which is currently the current Medicare program, although the VA does negotiation and gets drug prices much lower than our other government systems or the private market, and they do much better and are able to contain costs better that way.
Wow. It really is pretty unbelievable. There's some unbelievable stuff there. Okay, and so we recently saw you at Ilhan Omar's Medicare for All panel. You were on the stage with Pramila Jayapal and Aaron Murphy and a few other advocates.
Yes.
And that was really incredible. And could you talk a little bit about like how people at the national level and state level are working together to push for healthcare reform?
Sure. Yeah, that was quite an honor to be serving on that panel. I was very humbled, and to meet Representative Jayapal as the author of the national bill was really pretty amazing, and to kind of talk strategy a little bit with her before we got on stage was sort of a career highlight for me, without a doubt. The reality is it is a little harder to do under the current structure, a little harder to do single payer at the state level, obviously. mostly because we would have to get some federal waivers in order to take some of the money that is coming in from the feds and be able to basically put it into our state fund so that we could commingle all of our healthcare dollars together to make sure that we pay for people's healthcare, right? So there's no question that it would take a little bit, it would be a little bit harder. But that said, it's not impossible. And, there's two minds of this. Better to do it on a national level because that's where we're going to get an economic scale, of savings, right, on a national level. Plus, there's a humanitarian value to making sure that all of us across this country have the same access and cost to care, right? Not, Minnesota is different than Alabama, right? Who, or some of the states that refuse to even expand Medicaid. Right, and there are people suffering and dying from that decision, right? Yeah. So it would be better to do it on a national level. But we can, both our federal legislators and our state legislators, as far as what I could see, particularly with last Thursday night, are staying in touch with each other, talking about ways to support whatever the work is, whether it's at a state level or at a national level. Representative Ro Khanna out of California is getting ready to propose a bill that Representative Jayapal was the author of last time, but now that she's the Medicare for All author, Ro Khanna is going to carry the bill. And it really is a bill that would provide automatic waivers to any of the states who want to lead the way and implement a single payer system. I mean, when you look at Canada, they started by a province, right? The one right above us in Saskatchewan, and it proved to be such an economically valuable thing to do, to say nothing again of the human value of it, that they decided, the federal government of Canada just said, wait a minute, let's take a look at this and see if we couldn't do this more on a national level. And so if we need to be trailblazers, Minnesota's ready to do that with John Marty's bill, the Minnesota Health Plan.
Okay, well, and going from there, there's sessions out, and there's still some legislators who aren't supporting the Minnesota Health Plan, and there's also most of the federal representatives aren't supporting Medicare for All. Do you have any any final messages to people who aren't supporting either of those bills?
Well, here's what I would say, I guess, and this is a little bit blunt, but to those folks who aren't co-sponsoring, co-authoring these bills and helping us move this, they need to know that there are literally constituents of theirs who are dying under this status quo system. I'm not being hyperbolic, that's for real. People are making decisions about life and death based on money. What is radical and what is extreme is not moving to a publicly financed, privately delivered healthcare system. What's radical and extreme is people setting up GoFundMes for their chemotherapy. It's 26-year-olds dying in the richest nation in the world because they couldn't afford their insulin as a type 1 diabetic, and they started rationing, right, their insulin. It is people saying, you know what, I don't want to leave my family in debt if I can't beat this disease, so I'm going to just choose to accept death. That is actually happening. It's time for those folks, those legislators, to join us, to be on the right side of history, and to set their legacy up.
And I hope the legislators hear that point, and I hope they change their mind.
I do too.
It's pretty ridiculous.
So we just need the movement to keep bugging them about it, and we are absolutely doing that. By the way, the polls are stronger than ever about this issue. More and more people are getting excited about it. I am looking for the younger generation to really engage, because I don't know what access you all will have to healthcare in the future if we don't start to do something and start making these changes now. So I'm more hopeful than I've ever been that we are at or darn near a tipping point to make this happen.
I hope so too.
All right.
Well, thank you so much,
Thank
Rose.
you. Thanks for having me.
Yep.
Thank you.
All right.
Okay?
We're good, yeah.
Cool.